Our next speaker is Rainier Urdaneta. As I told you, he came to us from academia, and his work will speak for itself. So let him show you what he has done.
Right, so I came to Bicon from here, from Harvard. I was teaching full-time at the Harvard Dental School, and I was using Brandenburg, ITI implants. And then I went to take a presentation with Vin, and he was showing me all these restorations without cement, implants without screws, and my first thought was, are you mad? Anyway, I was given a chance to do an opportunity to do research, and this is what I have found in the last 10 years doing research with Bicon implants. I was taught that large crown-to-implant ratios will lead to bone loss. I came to Bicon thinking that splinted implants were necessary to protect bone, that longer implants were necessary in type 4 bone, that highest biting forces were created with implant prosthesis. This is what I was taught in my prosthodontic training, that excessive forces led to bone loss, and that the dental implants could not be placed in close proximity to neighboring teeth. I am going to challenge these statements, for these statements cannot be supported with the available scientific evidence. The first one was crown-to-implant ratio, and like Dr. Schulte, I did research on the subject. We went back and evaluated single implant restorations. I found, to my surprise, when I first started with this, that the majority of the research done on crown-to-implant ratio was done on splinted implant restorations. Frankly, the only research that has been done with single implant restorations were done with Bicon implants by Dr. Schulte and by our group. How do you evaluate the effect of crown-to-implant ratio on implants that are splinted is beyond understanding to me. But that's how it was done prior to this research. We have been following these cases prospectively since the year 2003. We have gathered information in 326 implants on 81 patients. 81 implants out of this, instead of losing bone post-crown insertion, they gained bone post-crown insertion. We evaluated more than 90 different factors, and we published the results of this investigation in the International Journal of Bone and Maxillofacial Implants. In that particular study, we found out that an increased crown-to-implant ratio has a significant effect in prosthetic complications. But with regards to a relationship with crestal bone levels, we found that crown-to-implant ratios of up to 4.95 did not lead to a significant increase in peri-implant bone loss. In fact, what we observed was the exact opposite effect. Let's look at this particular case, crown-to-implant ratio. This is a 4.5 by 6 Bicon implant. As you can see, not all of the implant is in bone at crown insertion. About 5 millimeters of it is in bone. And yet, more than 3 years post-crown insertion, we have had bone growth now. All the implant is in crown is within patient's bone, and we now have a smaller crown-to-implant ratio in response to the forces, in response to the bone growth. What I have realized over the years, and I think if you ask me what is the most significant finding of my research, is that like everybody else in the body, the response of bone to forces is mineralization. If you have osteoporosis, your physicians don't tell you, please sit down and be careful because excessive forces are going to lead to bone loss. They tell you the exact opposite. Your bones need you to work them in order to grow them. So forces lead to mineralization. If you have a case like this with 5 millimeters of bone remaining, what do you do in your practice nowadays? This is what we did in our practice in 2009, and I placed this implant. Small internal sinus lift and a 5 by 5 implant. How much pain does a patient go through when this particular procedure takes about, half an hour to be done? Very minimal. This is after healing. This is a crown at insertion, and this is 3 times the length of the crown. As you can see, the crown is significantly larger than the implant, and the bone response 2 years post-crown insertion is mineralization. It is obvious that the forces distributed over a smaller surface area, in this case, 5x5 implant, those occlusal forces are distributed, and then you get more forces between reaching the bone, and the bone's response is not bone loss to the first thread, and rather is mineralization. Another similar case, and as you can see before and after more than 3 years of function, the bone has changed its architecture and in an obvious way in the radiograph. Forces, and we can agree all that the quality of the bone in the maxilla is the worst, and you can see here that the response of maxillary bone is to change its architecture. This is all, as we know, what Wolff's law is all about. Forces will lead to changes in the bone, and those changes would be mineralization. Very minimal bone loss remaining in this particular patient. And what was the treatment provided at the Implant Dentistry Center? Did we do an external sinus lift in 2008? No. An internal sinus lift done by Dr. Shadi Daher in a webcast to London with a placement of 2 6x5.7 Bicon implants. And as you can see, the implants are pretty much swimming into sinus grafting. 9 months later, the implants were restored with single implant restoration. So you're probably thinking, well, this would be the case in which you will be asked to splint, right? Let's use the technique that has been, given to us. Let's splint and pray, right? And yet, what was done at the Implant Dentistry Center was we didn't splint, for we knew that the response to bone to these forces is mineralization, and as you can see, the radiograph speaks by itself. 2 years post-crown insertion, the bone has grown in response to those forces. Another very limited case, what would you do when the patient like this arrives to your office? I suggest that you do an internal sinus lift, and as you can see, the implant is placed and you lift the sinus and it's being held by the abutment. Another beautiful surgery by Dr. Daher, and 6 months later, you have some bone healing, you put it to restore, and this is 2 years post-crown insertion. This is how you start, and this is what you give the patient. This is minimal treatment with maximum effect. Another case, so that you know we're not just showing you the first 2 that work well for us, but rather something that we do all the time. And internal sinus lift, right? And this is what was obtained, 4 millimeters of bone during healing, and this is 2 years post-loading. The bone response to forces is mineralization. We have a case with 4.33 of crown to implant ratio at crown insertion. This is 2009. What's going to happen in here when we know that this particular implant is 8 millimeters long, but only 4 millimeters of those 8 are in bone? Well, this has to be the case in which we're going to lose bone to the first thread, right? Let's see what happens. This is 3 years post-crown insertion. What happens here is bone growth in response to the forces of, now we have 6 millimeters of the implant in bone. We have had bone growth coronally and apically. Now the crown to implant ratio is no longer 4.33, but 2.76. The response in the mandible is the exact same thing. We have a 4.5x6 Bicon implant place. It's restored with an integrated abutment crown, crown to implant ratio of 2.5. What's going to happen with this particular restoration with 4 years in this occlusion? It has to be bone loss to the first thread, right? Because that's what we were taught in dental school. This is what happened. The crown to implant ratio now is smaller for bone growth surrounding the implant have now made the crown to implant ratio smaller. Why does this happen? My belief is strongly that the increase in forces has the bone changing its shape, and in this case, increasing mineralization. All these cases with bone growth led us to start evaluating why these cases bone growth. And I have to accept that for me, it became an absolute obsession to understand why were these cases gaining bone. And when we define bone growth, this is what we were talking about. We have, as in the restoration on the first molar, as you can see, this is 2001, and this is 2008. It is obvious that in this particular case, we have a significant amount of bone growth over the 8 years of function. But what were the factors that were associated with this particular clinical finding? And as you can see, this particular, for those of you thinking that I just brought you the toothpaste x-rays, you can see here what happened over the years, 2001, 2003, till 2010, and how the bone growth was slow but steady over the years. This is the reason why these manuscripts were published. They were published because you can't argue with radiographs. These factors associated with bone gain manuscript was published in the International Journal of Oral and Maxillofacial Implants in November of the year 2011. In that manuscript, we evaluated more than 90 different factors. And frankly, you could have asked me, I became so obsessed, you could have asked me what, medications were taking the patient to every single thing they were doing during the day, and we knew exactly what they were doing before we needed to know exactly what were the factors associated with bone gain. Of those factors, we had 13 that were correlated to bone loss and 10 that were correlated to bone gain. Of those 10 factors, after placing them into a multivariate analysis, we found that 5 of them were correlated with a significant increase in peri-implant bone levels over time. The first factor was the presence of a hydroxyapatite coating, the type of restorative technique. Implants opposing natural teeth were significantly more likely to gain bone when compared to implants opposing fixed implant-supported restorations. One implant size out of 10, 5 millimeter wide by 8 millimeter long implants were significantly more likely to gain bone, and the daily intake of non-steroidal anti-inflammatory medications for the treatment of arthritic pain and or cardiovascular prevention. The first factor was the HA coating. We found dissimilar findings when comparing different coatings. HA-coated implants were significantly correlated to bone gain, and titanium plasma sprayed implants were correlated with bone loss. The observation that HA-coated implants maintain osseous crest is not new. It is known since the 1990s. The typical growth that you will observe on an HA-coated implant is, as you can see on this particular X-ray and the arrow showing, is a bone growth towards that HA coating and towards the implant abutment interface. And finding that replicated in different patients and was statistically significant. So what would happen if you have a 5 millimeter wide by 6 millimeter long Bicon implant in a maxillary, restoring a second maxillary molar in occlusion with a natural tooth? What would happen over the years? Are we going to continue to lose bone to the second thread, third thread, or what is going to happen? What happened over 40 years in here is that bone growth towards the implant abutment interface, as you can see, has slow, steady growth around the implant and around the HA coating on this particular implant. So does excessive forces lead to bone loss, or do they lead to bone mineralization? Of course, one of the limitations of short implants, and we have to understand when to use them and when to not use them, is the fact that we cannot restore the profile, the soft tissue profile. So in maxillary anterior areas, there may be moments in which you need to do graftings, but for posterior areas, we can all agree that is not necessary. The second factor associated with bone gain was the presence of a spherical base on the abutments. As you can see here, the restorations, either porcelain physiometal crowns or integrated abutment crowns, if they had the titanium spherical base, they were significantly more likely to gain bone. When that spherical base was removed, like in the case on the right side, and replaced with composite, then a Bicon implant lost significantly more bone. The placement of composite on the base of an abutment was the most significant factor associated with bone loss, and it was a factor that was, as you can see, highly statistically significant. So the presence of the titanium spherical base was then one very important factor in bone stability and bone growth. The reason for this is the fact that, of course, composite accumulates more plaque, but also force distribution. This implant was designed so that forces would be distributed to bone, be at the base of the spheric of the abutment, and by loading that area coronal to the implant abutment interface, then we maintain bone. This is a theory that is obviously supported by clinical cases. In this case, 13 years post-crown insertion, you can see that below the spherical base, we have had a significant amount of mineralization that is in response to, and it seems obvious to me, to my eye, that is related to force distribution. This case is 9 years post-crown insertion. As you can see, again, mineralization. And what's most interesting about this is that the base of the abutment and the Bicon implant is polished titanium. So we obviously do not have osseointegration, but what type of relationship do we have in which we see further mineralization in that base? I believe one of force distribution. So what happens if we change the composite abutment base with a titanium spherical base? Can we regrow the bone that's lost? This is what we did in this particular case. This was the daughter of one of our dental assistants, and as soon as she heard that spherical base was needed, she said, "You better change the restoration of my daughter." So 6 years, as you can see in here, 6 years post-crown insertion, we've had bone loss to the first thread and second thread in some areas with the use of composite. When we replace that spherical base for titanium, we were able to remineralize that bone and regain some of the bone lost in a period of only 6 months. The third factor associated with bone gain was implants opposing natural teeth. That was a complete first for me, and I went to Dr. Morgan and I said, "Dr. Morgan, what do you think this is? Why would teeth with implants opposing with natural teeth would gain more bone than implants opposing implant-supported restorations?" We have this is my last manuscript. It's going to be published next year in the Clinical Oral Implants Research, and in this particular manuscript, we debated this particular theory. We found that significantly lower bone loss was documented on implants opposing natural teeth when compared to implants opposing implant-supported restorations. We also found out that an opposing natural tooth was associated with bone gain for HA-coated implants placed in the mandible. But why? And we will see that in the majority of the cases that gained bone, they were occluding natural dentition. And it didn't matter if the cases were occluding non-restored teeth, teeth with crowns, or what mattered was that they were opposing a natural tooth instead of an implant. Some authors, in this case Dr. Misch in his latest edition of his book, has suggested that lack of proprioception on opposing implants may magnify the load around fixed implant-supported prostheses in partially edentulous cases during parafunction, and that the highest forces are created in implant prosthesis. There are two things we're saying in here. One, that implants lack proprioception. And two, that the highest forces are created with implant prosthesis. Neither of these two statements can be supported with available scientific evidence, and this is the reason why this statement in the book has no references. So we know that implants have proprioception, and it's called osseous perception. Osseous perception has been evaluated in teeth and in implants in the same way, in a way of active and passive discrimination. It is well known that active discrimination between teeth and implants is very similar. The question becomes, what is the difference in passive discrimination? We do know that the threshold of minimal pressure perceived in implants is significantly higher than on teeth. What does this mean, however? This means that implants are able to discern forces from 3.4 newtons and on, whereas teeth are able to discern forces from 0.3 newtons and on. So the difference between teeth and implants is the difference between 0.3 newtons and 3.4 newtons. How is this clinically relevant? How many of you have patients with occlusal forces that are averaging 3.4 newtons or less? How about 400 newtons for an average? Or 150 or 250? Those are the averages. So the fact that patients cannot discern between 3.4 and 0.3 has no clinical significantly relevant for us. For patients, if they can discern between 3.4 newtons or more, they can discern all the biting forces and much more, all the biting forces that are received. So, in this particular, with regards to forces, we know that every single piece of research done in the subject have shown the same thing. Forces on patients with natural dentition are higher than forces in patients with fixed implant restorations. Every single piece of research have said the exact same thing. In fact, there is not one that says that forces on implant restorations are higher than forces on natural dentition, and yet we are educated in dental school that forces on implant restorations are higher. I don't know where that is taken from, but certainly not from research. So occlusal forces higher on teeth than on implants. So we conclude, we actually hypothesize in this new investigation that the crestal bone mineralization observed on those implants opposing natural dentition was a response to the increased local strains engendered by the natural opposing teeth during functional occlusal loading. In other words, higher forces led to mineralization. The fourth factor associated with bone gain was an implant size 5 by 8. We found out that 5 by 8 implants were significantly more likely to gain bone. We also found that there was a significant difference between maxilla and mandible, and that 5 by 8 was significantly associated with bone gain in posterior mandible. We were crazy enough to have this particular information peer-reviewed by the Journal of Periodontology, and after a grueling review, it was published on the October issue of 2012 of the Journal of Periodontology. In this particular manuscript, we concluded that 5 by 8 implants demonstrated statistically significant less per implant bone loss in posterior mandible. There were two findings that I found in the particular study. One, that 5 by 8s gain more bone, and two, that short implants give periodontists stomachache. So the second factor, okay, so, all right. Now, the final factor associated with bone gain here were the patients taken, the medications the patients were taking, and this was a complete finding for us. We evaluated every single medications the patients were taking for the first time in the literature, by the way. There is no other research that has been published that has shown, even though our patients are taking all these medications for the treatment of systemic conditions, we have not considered any of these medications in previous research. Now, I can tell you now that patients taking the most common medications, which are statins, were not correlated with changes in periimplant bone levels. But patients with diabetes taking or not taking medications to lower blood sugar were significantly more likely to lose bone. And patients taking non-steroidal anti-inflammatory medications were significantly more likely to gain bone. An implant was significantly more likely to gain bone if the patient was taking non-steroidal anti-inflammatory medications, an effect that was specific to HA-coated implants. This is not the first time in the literature that the intake of NSAIDs have been shown to reduce bone loss, and in this case, even increase bone density. That was done in the year 1995 by a double-blind randomized clinical control trial with a different implant system. Fifth, this factor, as you can see here, the first case that I show you had a patient that was taking non-steroidal anti-inflammatories. And when we asked, and in some instances we actually had to go back to the medical and the pharmacy records to know exactly how much medication the patients were taking, we figured that this patient was taking 1,600 milligrams of ibuprofen a day to control arthritic pain. And you can see the significant amount of bone growth that was correlated with this. 7 years post-crown insertion, you can see a significant increase in crestal bone levels in these patients taking 600 milligrams of ibuprofen one day, 650 milligrams of aspirin the other day. And significant amount of bone growth, as you can observe here, with the patient taking 325 milligrams of aspirin 4 years post-crown insertion. Another significant case in patients taking non-steroidal anti-inflammatory medications. Another significant gain, but the patients were doing similar things. They were taking, some of them, significant amount of non-steroidal anti-inflammatory medications. Why do we think this happened? We have placed a theory in the manuscript that Dr. Daher helped me figure out, in which as we know, non-steroidal anti-inflammatory medications block the formation of cyclooxygenase enzymes, reducing the formation of prostaglandins. What I didn't know was that prostaglandins have a biphasic effect in bone. That is, if you have prostaglandins or lower amount of prostaglandins in the tissues surrounding the implants, you have an environment that increases replication and differentiation of osteoblasts and leads to bone growth. If you have an increase in prostaglandins in the tissues surrounding the implants, the effect is the reverse, and you lead to bone loss. So our hypothesis in this study is that the daily intake of non-steroidal anti-inflammatory medications reduced the amount of prostaglandins in the tissues surrounding the implants, creating an environment that was conducive to peri-implant bone growth. We have now started using aspirin to regrow bone in patients that have been lost, and we use aspirin because it's widely used and because animal studies have shown that there are several pathways in which aspirin can actually lead to peri-implant to bone growth. This was the first case we did utilizing the aspirin to regain bone. In this particular case, you can see we have a patient that had been stable for 3 years. As a prosthodontist, I saw the interproximal contact being lost, and I thought, no. I have to immediately add this. Now I have changed my mind, and I prefer bone to interproximal contacts any day now. Anyway, we removed this restoration, and we added the interproximal contact, and 6 months later, the patient came with an infection and bone loss on the implant. I had two choices, to treat this or to move to Maine. I chose to treat the case, and then said, all right, we have 5 factors associated with bone gain. This patient this is a 5x8 implant. This is occluding against natural teeth. It's an implant that has an HA coating, but I have 2 factors that I could change. I could add a spherical base to this restoration, and I could place the patient in non-steroidal anti-inflammatory medications. This patient was placed on then. We removed the restoration, took an impression for a new restoration, and placed a non-shoulder abutment with a spherical base. We placed a restin on the base of the abutment, and we instructed the patient. We also placed the patient on 500 milligrams of amoxicillin for 10 days, and we instructed the patient to take aspirin, 325 milligrams of aspirin. In his particular case, he took it twice a day. This is the before and after of the treatment. We were able to remineralize the bone surrounding this particular implant with the use of aspirin. The question became, what happens if you reduce the 325 milligrams to 81 milligrams, which is that's what the physician had suggested, and this is a year and a half after the amount was reduced to 81 milligrams, showing that the bone remained stable. Then I was sent another case. We uncovered this case in 2010. We placed an on-shoulder abutment, and the dentist restored it with a porcelain metal crown. A year and a half later, he sent us a case. We're losing more bone. Again, 2 choices, Maine or restoring the case. So I went with restoring the case. We did diode laser, placed a restin, and asked the patient take 325 milligrams of aspirin, and after 6 months of treatment, we were able to remineralize the case, and we sent this particular view back to the dentist, in which we were able to then remineralize this and restore some of the bone loss. The next manuscript we investigated, and Dr. Sean has already talked about it, so I'm not going to go over too much, is the survival of ultra-short locking taper implants, which was published in this year's May issue of the International Journal of Oral and Maxillofacial Implants, and there was no statistically significant difference in the survival of ultra-short when compared to short Bicon implants, and we demonstrated that the survival of 5x6 Bicon implants was similar to the survival of 8mm long Bicon implants. So what happens if you restore a maxillary premolar with a 5x5 implant, even though you have kilometers of bone? You choose to utilize a 5x5 implant. What would happen? What happens, I think, is obvious from this radiograph. Bone response to increasing forces is mineralization. We have several techniques and alternatives, but we have to consider them seriously. For if we have 7 millimeters or less of bone height remaining in posterior mandible, what is the best alternative for our patients, if not the placement of a short, an ultra short implant. This is what I believe was yesterday's implant dentistry, splinting shorter implants and then placing a long implant. In this particular case, you can see the mandibular nerve was damaged and the patient's lost the sensibility in the lower right lip because the dentist was using the whole rationale. If I am going to place, a single implant restoration in the mandible, I better use something really long. Came to us, Dr. Daher evaluated the area and said, oh, I don't think so. We can place 5x6 Bicon implants. We can restore them 3 months after the placement. We can then do them with single implant restorations with molar-sized teeth instead of premolar-sized teeth. 1 year post-loading, the bone is better than at loading. And interestingly enough, in the same patient, similar areas of the mouth, the longest 5-kilometer implant is the one losing the most bone. And when you have here, you have 3 implants to restore 2 teeth on one side. Yesterday's implant dentistry, and today's implant dentistry, 3 implants restoring normally sized teeth on the left. This is important because the patient has much more surface area to bite on one side than on the other. Why is the survival of ultra-short implants the same as the survival of longer implants? Because the case supporting the strain-induced biologic response of bone is compelling. If you type in Medline forces and bone, you get a myriad, an excessive amount of information. If you type excessive forces and bone loss, you find a lot of publications poorly done and in dentistry. In fact, the last evaluation of the literature in the subject of excessive forces and bone loss concluded, and this is taken from the abstract, a causative relationship between loading conditions and marginal bone loss has not been demonstrated. So why are we taught in dental school that excessive loads lead to bone loss when this relationship has not been demonstrated is something I just don't understand. The other reason why these implants work, I think, is because they are wider than conventional implants. I truly believe this is a factor. How do we define excessive loading in dentistry? We define it by cantilevers, right? We define it by grinding, and we define it by short implants, right? We define it this way, crown-to-implant ratio. So what if we put all these things together? We have a patient that obviously grinds. We have lack of posterior support, another factor that increases forces. We have a cantilever mesial to that implant, and we have a patient that grinds. What is going to happen here? The consequences are prosthetic. Prosthetic restorations may not be able to take the load. The bone, on the other hand, can. As you can see clearly here, bone's response to an increasing forces is mineralization, not bone loss. So how short is too short? Is there a threshold? I believe if you're going to restore an implant, a molar or a premolar with a 2.8 millimeter wide by 8 millimeter implant, that is too small. That is not enough. In this case, and why is this possible? Why is this the case? This particular study, I think, explains the relationship in a very clear way. If you have 2 implants of similar length, they are 12 millimeters long, and you increase from 3.6 to 5 millimeters in width, only increasing the width by 1.4 millimeters, it reduces stress by almost 50%. Now, if you have implants of similar width, in this case 3.6 millimeter width, and you increase length from 8 to 17 millimeters, you reduce stress by only 7%. Width is much more important than length any day. So in this particular case, give us an idea of how this is so. We have a 2.8 by 8 implant restored that we decided to restore. It was placed there temporarily just to help us immediately load the case, but we decided to let's restore it. And we had also 4.5 by 6 Bicon implants next to it working. 2 years after the implant, the 2.8 by 8 implant lost integration. But if you were to measure bone loss from the crest, we didn't lose any bone. For the rationale of bone loss to the first thread and then second thread and all these things, it's simply not true. What happened here is what I believe is the effect of excessive forces in bone. If you can break the bone, if you can fracture the connection, and in this case, occlusal forces fracture the very weak connection between a very thin implant and bone, then you have excessive loading. In the same case, 4.5 by 6 Bicon implants continue to perform perfectly. So 4.5 by 6 to restore molars and premolars is just more than enough. For you as surgeons, this gives you the opportunity to restore cases like this, very close to the nerve, 5 by 5 implants, place and restore on right and left in this particular patient, very close to the mandibular nerve, and you can restore them, and you can expect that in unsplinted implant restorations, the results were going to be positive. The last research I want to talk to you about today is locking taper implants placed in close proximity to adjacent teeth. We found out, what do you think it happens when you place Bicon implants in close proximity to an adjacent tooth? We found in our first investigation that in some instances, there is no negative effect. The implant is really close to an adjacent tooth, and yet what happens is significant mineralization of the bone. Now the prognosis of the adjacent tooth is better 4 years, actually 5 years post-insertion when compared to this initial placement. So for me, it became a question. What is the effect? If I'm going to do something in the mouth, I need to research it first. I need to know that what I'm doing, and I've looked at many different records over the years, but I need to have an effect. I need to know that if I place a Bicon implant 1 millimeter or less to an adjacent tooth, that I am not going to lead to root resorption, that I'm not going to lead to the adjacent tooth needing a root canal or extraction. For that, we set up this particular retrospective cohort study, 203 patients who received 242 Bicon short implants that were followed for an average of 42 months. 46 of these implants were placed less than 1 millimeter to an adjacent tooth. There were 9 implant failures for a Kaplan-Meier survival rate of 96.3%, but there were no implant failures in the less than 1 millimeter group. Placement of a Bicon implant less than 1 millimeter to an adjacent tooth was not associated with root resorption. There were no cases of root resorption, no cases of endodontic treatment, no cases in the patient reported pain post-surgery, and no extractions of adjacent teeth in this particular cohort. We found also that there was no significant difference between crestal bone levels of implant placed in close proximity or further apart. There was no relationship simply between placement or distance to an adjacent and crestal bone levels. But why is it so? This implant has a sloping shoulder. So if you place the implant, like in this case, less than 1 millimeter to an adjacent tooth, you still have a significant amount of space between the implant abutment interface and the implant for the implant narrowers to the abutment, which is much smaller in size, providing significant space for bone growth and papilla. In this particular case here, we have 3 years post-crown insertion. It's a 5 by 8 Bicon implant. And as you can see, very close proximity to an adjacent tooth. And what we have is actually a significant amount of space for bone growth over the years. Very close proximity to an adjacent tooth, no significant changes in peri-implant bone levels 3 years post-implant placement. Very close proximity to an adjacent tooth, no significant difference in crestal bone levels with a 5 by 5 in the mandible. Very close proximity to an adjacent tooth, no significant difference in peri-implant bone levels. So I have seen Shadi Daher and Donahue and all the famous surgeons and Dr. Morgan and all the surgeons placing these implants so close to an adjacent tooth over the years, and I've looked at the x-rays, and I have never found any case in which we have root resorption. So for example, I placed this particular case myself, and of course, yes, I sweat a lot that day, and but we did it very slowly, and then we realized, and then you see another case here, a 5 by 8. We have obviously more space on one side than on the other, but no significant differences in peri-implant bone 4 years post-crown insertion. So we conclude in this particular study that short plateau design implants placed less than 1 millimeter of an adjacent natural tooth did not cause damage to the adjoining tooth and demonstrated similar peri-implant bone stability when compared to implants placed more than 1 millimeter. And some of the clinical cases we've done over the years, as you can see in here, we have a 4.5 by 6 Bicon implant, very in close proximity to an adjacent tooth, restored with an integrated abutment crown. This is 1 year post-crown insertion, and this is the clinical view of the restoration, 1 year post-crown insertion. Of course, as the years go by, then we get more and more close to an adjacent tooth, and I did this case, and I am a prosthodontist. All of you are oral surgeons, so if I can do this, you can do this with your eyes closed. So we measured this particular case, and we found that we had, about 7 millimeters coronally. But when we went down to the two roots, this is typical post-ortho treatment. They open up the spaces, but the root don't move, right? So we have now this particular situation. What do? Enter a 4 by 5. A 4 by 5 implant has 4 millimeters at the coronal part and 3 millimeters in the most apical part. A perfect implant for a clinical situation like this. It was placed. As you can see, we have plenty of bone because the implant in the top part comes out as a 2.5 abutment, giving you significant space for papilla. So this is placement and after healing. And this is when I uncovered, as you can see, we were having bone growth. This was 3 months after uncovering, and we were starting to get bone growth on top of the implant. And we took an impression, and the same day as the uncovering, and then we inserted the crown next day. Of course, breaking all the rules as usual, right? So we inserted the crown. As you can see, the tissue is fully mature. And we inserted the crown, and this was a crown insertion, and this is 9 months post-crown insertion. And you tell me, where is the bone better, when I placed it or 9 months later? And what is the bone response surrounding a 4 by 5 implant? Is it bone loss or mineralization? And do you see any damage to adjacent roots or root resorption or root canals in any of the adjacent teeth? And for those of you thinking you cannot have papilla, in this case we had what could even call, oversized papilla, growth. 5 kilometers of growth of papilla in this case. And a patient that is happy. So if the question is there scientific evidence to support the use of ultra-short Bicon implants? The answer is a definite yes. Thank you very much for your attention.